Hi, everyone, and welcome to today's webinar, Trauma-Informed Learning Collaborative, Moving from Theory to Practice. My name is Julie Hashida, and I will be the moderator for the webinar presented by the National HCH Council. This session is being recorded. It is a 60-minute presentation, and we reserve the last about 10 or 15 minutes for questions and answers. There is a pod below the presentation slide, as you may see on your screen. And at any point, you can submit questions for our presenters. Also, if you have any technical issues, you can submit those in the pod as well. If you're having technical issues, you can also call the Council's office at 615-226-2292, extension 222, and that phone number is also listed in that Q&A pod. A select number of questions for our presenters will be answered at the end of the webinar during the Q&A session. If we don't get to your question, we will have everything logged, and we will provide those questions to the presenters for a written response after today, after the end of the webinar. The PowerPoint presentation, the slides, and the recording of this webinar will be posted on our website at www.nhchc.org within 3 business days. This activity is made possible by the Health Resources and Services Administration, Bureau of Primary Health Care. Its contents are solely the responsibility of the presenters and do not necessarily represent the official views of HRSA. So I'm really grateful to be co-presenting today with these individuals. We have 2 members from the Council's Trauma-Informed Organization Learning Collaborative. And this is also an order of the presenters today. So we have Krista Brown-Lee, who is the Vice President of Administration at Village Family Services in North Hollywood, California. Then we have Laura Camerato, who is the Housing Readiness Coordinator at Cascade AIDS Project in Portland, Oregon. And of course, my co-lead on the project at the Council, the lovely Katherine Cavanaugh, who is also the consumer advocate for the Council, and she is located in Baltimore, Maryland. After today's presentation, our hope is that you will be able to do these things on the slide. So describe our 3-year learning collaborative, including its structure and our goals and objectives. Also explain the elements of a trauma-informed organization. Explain the elements of an organizational assessment tool, and discuss special considerations for assessing programs serving people experiencing homelessness. And at this point, before we review the agenda for today's webinar, we have a poll we would appreciate you all participating in. We really want to know, and you can select all that apply to your program, but we want to know what steps your organization has taken in a trauma-informed transformation. So there's several options listed on your slide, and the results should be broadcasted on your screen. So we'll give everyone just a few seconds, maybe 30 seconds to respond. We have about 100 participants online today, so we hope to get as many individuals to respond to this poll. And it looks like conversations with staff or leadership about trauma-informed change process or organizational implementation is taking the lead at this point. So at least almost half of you all have done that step at this point. And many of you all have conducted an all-staff training on trauma, trauma-informed care, and then including trauma or trauma-informed discussions at all staff meetings. And then maybe just a handful, a few folks have actually completed an organizational trauma-informed assessment. So this is really good information for us to know. I think at this point it might be okay to close out the poll. Thank you, Hannah. So today I'll be covering this first bullet point around the learning collaborative structure and process. Just give a brief overview, talk a little bit about the first year, our preparation and work phase. Then I'll pass it to my co-presenters who will cover trauma-informed approaches, how to assess, and what, in answering the question, what is a trauma-informed organization, and then we'll wrap up with a Q&A. Okay, so just quickly a brief overview. If you want a detailed description, we conducted a webinar in November of 2017 that went into detail that described the Learning Collaborative, our vision, goals, purpose for the 3-year project, as well as a lot more detail about the work that we were planning for this first year. So if you're interested, you can go to the link on the slide and view that recorded webinar. But the purpose of this 3-year project is really to help organizations in this transformation of their policies and practices so that they can address trauma symptoms, the etiology of trauma, and prevent any additional or further trauma. Each year of the project, we utilize the learning collaborative structure, and each year it's on a fiscal year, so starting from July and ending in June. And each year we had a different goal and objective. So as we're wrapping up this first year, our plan was to identify an assessment tool and develop the organizational change plan. In year 2, the Learning Collaborative will implement this selected assessment tool. So all of the Learning Collaborative members will implement the same assessment tool. And then in the last year, the 3rd year, our goal is to take what we've done over the past 2 years and develop a toolkit to share with the public on a national level. And the structure of the Learning Collaborative is modeled after the National Child Traumatic Stress Network guidelines for a Learning Collaborative, and primarily that's just 3 components. So the interactive or learning sessions, the action periods, which happens in between the learning sessions, that includes all the homework or any additional work in between the learning sessions, and then our one-on-ones. And I'll describe what that looked like in year 1. But as part of our, Katherine and my preparation for the Learning Collaborative, our goal was to create a microsystem within the Learning Collaborative to reflect trauma-informed principles. Also, as part of our preparation, we were planning the content and flow of the session. So we had 6 sessions, 1 each month, and we were planning the flow so that we could meet our goals and objectives for the year. And then lastly, of course, we wanted to identify which programs would participate and help us meet this goal. And so this slide talks a little bit about the application process. So we opened up an application last November. We had it open for a month, closed it in mid-December, and at that point we had 29 total applicants. And we only had 10 slots to fill. And this was difficult for us because there were so many strong applications, really great programs that were enthusiastic about this work, about their transformation at that programmatic level, and just passionate about trauma and addressing trauma. So it was really difficult for us to have to turn down a decline of 2/3 of these really great applications. What we ended up with was, we believe, a very diverse, very strong group of 10 programs. And we selected these applicants primarily on the strength of their written application, of course, but also the diversity representation they brought to the group. The diversity was around what's listed on the slide here. So program type, although the majority of our Learning Collaborative members are health centers because that's our targeted population, within that group there is a variety of types of health centers. So we have community health centers, so programs that receive both the E funding, general population funding, and then the H funding, the homeless services funding. We also have programs, health centers that receive H only, homeless services only, and then we have kind of that unique structure of the community health center within a public entity like a local health department or public health department. We also have programs that are shelter-based. We have a social services programs. We also have diversity as far as the special subpopulations. So all of these programs are serving people experiencing homelessness, but they may have programming that's targeted toward families, youth, or primarily Spanish-speaking populations. And then also a diversity in services. So primary care is part of the community health center, but we also have medical respite program and housing services. And this is just a few of the examples. We have it's more detailed, the full list. But lastly, the diversity around the experience with becoming a trauma-informed organization. So some of these programs have been, some of our members have been doing this work for several years, so maybe on and off or stop and go over several years. We had programs that are starting off very strongly initiating these changes and just happened, the application opened kind of in the middle of that, so they're smack dab in the middle of this work, intensely doing this work. We had programs that were a lot more newer to this concept. They were having conversations with administrators, with their staff, but they hadn't really taken some of these steps that we've listed in the poll just a minute ago. So a variety of experience and diversity on that level. And just quickly, with our work phase for the first year, our kickoff session was in January, and then we had one interactive or learning session each month. And then we also had an opportunity to meet in person in May during the national conference that we had in Minnesota. And our monthly sessions, we had guest speakers, and we also had time set aside for discussion. But as I mentioned, the flow of the sessions to meet our goals, as far as progression, was first to build this baseline knowledge for the members as far as what is trauma-informed care, what's the difference between trauma-informed care and trauma-informed organizations. We really wanted to build this common language. So this is what was happening, January, February, March, and then also developing this group culture. We did set aside time, and that's when we had our guest speakers and our homework, our articles that we asked the group to review reflected this desire to build this baseline knowledge. But we also did set aside time for discussion. But as the monthly sessions progressed, and as we are kind of getting closer to the end of this year, it's been more focused on the getting feedback about the assessment tool. So toward the end, it was more focused on, the homework was more focused on reviewing the various available assessment tools and then getting that feedback from the group. And now as we're wrapping up the end of the year, we're really working toward developing this tool and putting the tool together. As I mentioned, the homework assignments, the members can attest to, it was very front-loaded, several articles, scholarly academic articles, but also articles that are available online to the wider public. We had webinars, a podcast, various tools around trauma, around maybe more broadly organizational change. And then lastly, the last piece of the component of a learning collaborative is the one-on-one meetings. And the purpose of the one-on-one meetings was to build that relationship with our learning collaborative members. As you can imagine, having about 15 people on a call for an hour and a half each month, not everyone's going to get all their questions answered or provide all the feedback. So these one-on-one calls were very informal and really for us to build that relationship but provide space for the members to have conversations with Katherine and I and for us to get more in-depth feedback. And we did those bi-monthly, so each program had 3 calls. for this first year. And then we also, as part of the application, asked the C-suite representative for the program, so your chief executive officer, executive director, COO, whoever your C-suite representative was, to have 2 calls with us during the year. And that was to, at the beginning, to provide an introduction to the project and answer any questions. And then the last call, which will be held in July, is to get feedback on our final tool. Before I pass it to Krista, our next speaker, I'll wrap up with the next steps for this year. So we're wrapping up in July. We are finalizing our principles and domains for our assessment tool, and then drafting that assessment tool and then getting feedback to finalize it. In year 2, which will start toward the end of September, we'll be focusing more on developing that organizational change plan, conducting the assessment tools locally, so each of our Learning Collaborative members will conduct that assessment, and compiling those results, and then from that developing local recommendations. Again, if you want a little bit more detail, we have that on the link to the webinar in November, and I'm happy to answer any questions about the project, but at this point I will pass it to Krista.
Thank you so much. Good afternoon, everyone, and thank you for joining us today. I kind of want to start by saying that we were just so happy to be chosen as a participant in the Learning Collaborative. We were very, very happy to apply, as we felt like the Learning Collaborative was definitely something that was in line with our long-term goals. So as an agency, we have the support of our upper management and know how important a trauma-informed organization is, but we needed to be able to make a more concentrated effort into making sure that we had the right assessments and that we were able to implement this throughout our agency and not just in our service providers or in moving from a trauma-informed care approach to becoming a trauma-informed organization. Through the work that we had done before joining the collaborative, we knew that we had work to do, and our ultimate goal is to really be able to ensure that our agency is looking at trauma-informed practices from the time an employee applies with our agency all the way through to the time that they retire, so that we are not just focusing on the trauma-informed care, but that we are embedding this into our culture and into our practices and into our daily work. We really believe that the collaborative is going to provide us the structure to be able to do this and to have an entire agency-wide implementation. Our agency has been providing trauma-informed care practices for much longer than we were mandated to or required to. We are in California, and our mental health contracts require that we use evidence-based practices to provide TFCBT or other trauma types of treatments. We have been working to make sure that all of our practices and our care are happening throughout our social care. So for us, we consider social care our foster care and intensive services foster care. And our agency in the last 3 years has moved into providing homeless services. The homeless services that we provide are for the transitional age youth, and we know that it takes a lot of effort in working with that population, and we needed to make sure that we were putting things in place, again, at that location from the time a client walks through the door to the time that hopefully we've had them housed and they're able to recognize that we're not re-traumatizing them and that we're putting our best foot forward in our assessments and in our environment. Over the years, we've definitely realized that in our clinical staff, we've become aware of secondary trauma and its effects. However, I think sometimes we've missed the mark with our peer staff or our peer support staff or providers who are working in other areas other than just mental health services. And so we are taking the approach through really the vision and mission of our co-founders who serve as our CEO and COO, and their understanding of trauma and being able to incorporate this into the agency. I know a little bit in the Learning Collaborative we've seen where some agencies don't have that support from their executive or C-suite levels, and we were blessed to be able to have that, but it does take some work for some of the other folks in the Learning Collaborative. So our goal is to transition from providing services into really making sure our agency is overall trauma-informed. Some of the plans that we've been talking about, and a little bit of this is jumping ahead of where we are in the Learning Collaborative, but our end game and our plans are including things such as our new employee orientation. We want to update our training, our onboarding. We want to make sure that our facilities team is trained. So when they're putting things in our lobbies or they need to put signs up, that our approach for our clients is not a no, you can't do this or no, you can't do that, but trying to use language that is not re-triggering or that would create further trauma. Also, our policies and procedures that we've been looking at regarding self-care, wellness for our staff, and not just the service providers, but everyone from our finance team to our engagement and reception team. And we're hoping that throughout the process of this Learning Collaborative, we're able to start using the proper trauma-informed language across the agency. We definitely understood that we needed assistance with best practices in doing so. The Learning Collaborative has been amazing in that we have a diverse group of people. It's very collaborative. It allows for sharing ideas and feedback, samples, things that we've all been working on. And additionally, as was mentioned earlier, there was a lot of homework that was front-loaded, and the homework has been a little intense, but it absolutely has I think changed our mind as an agency as to a model that we were thinking was good for our agency, which was the sanctuary model. And through all of the homework and everything, we've been able to look at the Thrive model is resonating a little bit best with us. But as part of the Learning Collaborative, it's us building our own assessment and taking in certain domains that are in line with our values, the values of our agencies, whether it's our CARF accreditation, JCO accreditation, COA accreditation, or the mission and values. So for anyone who's not familiar with those models, some of the domains that we're looking at and we're reviewing are safety, youth and family empowerment, trauma competence, trust, and the real true commitment to ensuring that you're taking a trauma-informed approach, you're building it into your philosophies and into what you're doing as an agency or organization. So again, to just say, I think that the Learning Collaborative has been invaluable. We are really using this to inform our choices as the best approach to use for our agency. The perspectives from the other group members have been invaluable, and right now our group, the Learning Collaborative, is moving towards the assessment phase. And at this point, we're hoping that the assessment will be able to identify our areas of strength and areas of opportunity as in becoming a trauma-informed organization. So I know I'm going to pass this over to Laura now. Laura is going to talk to you a little bit more about the assessments and what's been happening.
All right. Hello, everyone. My name is Laura Camerato, and I'm going to be sharing a snapshot of Cascade AIDS Project's journey towards becoming a more trauma-informed organization. So we'll start with who CAP is and what we do, what encouraged us to prioritize TIC, where we're at in our process, and what we hope to accomplish. And I just want to echo what Krista was saying, that we were really happy to be a part of this Learning Collaborative. So CAP is a community-based nonprofit. We're a provider of HIV services, housing, education, and advocacy in Oregon and Southwest Washington. We have a separate specialized healthcare center for the LGBTQ+ community, and that clinic is called PRISM. We also have a variety of programs, and that includes peer support, testing, insurance navigation, rental assistance, and much more. I provide housing and supportive services to folks who are homeless or at risk of homelessness. And similar to what Krista had mentioned, prior to the formal establishment of a trauma-informed committee at CAP, we knew that this was something that was important in the social services sector, but need was reinforced by listening to the experiences of participants and staff. And we now recognize some of the feedback that we were getting as common TIC domains, but there were trends that emerged around topics such as safety, transparency, and how services were being provided. We then looked at leadership buy-in, which, echoing what was previously said, was imperative to this work. The agency's commitment to TIC was affirmed and recognized as an objective for the entire agency by the executive director, and that also includes where we post job descriptions or job opportunities, who is on those committees, who is represented in leadership, and so on. But establishing leadership buy-in was great to open up the conversation and recognize ways that pre-existing committees at CAP could work together. It got the flow of ideas going, and it helped us to reduce the duplication of work. In terms of pre-work and research, we looked at what other organizations were doing. So in addition to being part of the council, and we now have our own committee at CAP, I'm also part, alongside other CAP representatives, as part of a larger multidisciplinary trauma-informed learning collaborative with Ryan White grantees in our area. And this has been a great opportunity to share ideas, bounce things off of each other, set goals, and learn. So having different agency representatives come together to work on agency-wide initiatives that will be implemented for the populations that we collectively serve has been really helpful. One of the things that group did was pull up the Trauma Informed Oregon website, which I'll be referencing throughout this presentation. It was a great resource, it's super helpful, and they have this roadmap on their website. So one thing that you can do is go through this, and if you scroll over the different areas of the roadmap, there's links and resources that go more in depth about how you can implement trauma-informed care at your organization. On the left side, what you see is what you need to have to begin the process of implementing TIC, and on the right, what you need to do to start planning and making changes. And some of these things were already sort of part of our workflow, but having the agency-wide communication and the ongoing education and training has been really helpful. So I would strongly recommend giving their website a look. When we moved to staff recruitment and established the need for the trauma-informed work group, we sent out an invitation via email to all staff, and we also presented the opportunity to join its staff meetings. We stated the specific intention of creating sustainable trauma-informed practices at CAP, and staff at different levels and from different departments were approached to join. So right now our group reflects directors, managers, frontline staff, and people from development, prevention, and education, as well as housing and supportive services. And those that were interested in attending and being part of the work group were asked to familiarize themselves with the TI Oregon website as well as the roadmap before our first meeting. So once we got together as a group, we established that we wanted to use the standard CAP group agreements, and we revisited them with the TI lens. We had collectively identified the purpose, we acknowledged power dynamics, and we decided that we wanted to make this an open group to any staff member who could join at any time in the hopes of making this an agency-wide initiative. So we started the CAP TI work group in November. We meet monthly, and right now we have about 12 people. We were intentional about creating a warm environment while we jumped into the work, and we used How to Have a Trauma-Informed Meeting outline off TI Oregon to inform our efforts. We're doing our best to model the practices that we'd like to see put in place agency-wide. We were transparent about what some of the limitations of this group may be, though we may not be able to resolve all outstanding issues, that participation is voluntary, and that talking about trauma can in and of itself be re-traumatizing. Additionally, we established representatives from the work group to provide check-ins with our Community Advisory Board, and the CAB is comprised of participants in CAP's programs, and another representative to provide check-ins at the executive committee meetings that happen with the directors, and each of these meetings happens monthly. In our first meeting, actually the first few meetings, we did brain dump activities and created an exhaustive list of goals. We then separated them into participant or staff goals, environment or physical space, and a separate goal to create an implementation model to sustain the work. We recognize that shifting organizational culture would involve micro and macro changes, and as you can see, our list included everything from a solo self-care space to a TI-influenced onboarding process. As we've continued to establish these goals, we've crossed off some of the ones that were a little bit easier to accomplish. So we took staff photos, we bought fidget toys, and then the next thing that we tackled was trainings. So prior to seeking out specific TI trainings, CAP had already had in place trainings as part of our ongoing education efforts in our ability to affect health equity and provide the best services. We asked for these specific trainings to be available to all staff and moving forward available to new staff, and that they continue on a quarterly basis. Additionally, the Housing and Supportive Services Department brings in community members to share resources and present trainings to us on a regular basis. Previously, CAP had identified goals to become a more trans and culturally affirming workplace and provider of services. As part of our ongoing Black Communities Consultant Project, we had a training on the topics of power and privilege in healthcare, historical trauma, stigma, and sexual concurrency. Following this, we had a training on microaggressions and implicit bias. We also received a Trans 101 and Trans 202 training to deepen our understanding of trans identity and intersectionality. And what we found was having an implementation plan in place before the trainings is the best way to set people up for success, so that when folks have the trainings, they know how this is going to show up in our policies and procedures and what to do with the skills that they learn in those trainings. Next, we use several assessments to identify our agency's baseline. And the assessments can be done in many different ways depending on your agency's needs. Internal staff can do an assessment. You could also consult with somebody external to bring in people to work with your team. So there's external consulting available. The assessments can be formal or informal. There are many different styles of assessments out there, and the questions that you ask can refer to what your organization considers to be its guiding principles. Going back to the Ryan White TIC Learning Collaborative, we worked collectively on this goal to augment the standards of practice for TIC in Oregon, and we developed an all-staff assessment that we felt was the best fit for our staff needs, the populations that we serve, and some of the conversations that we had previously been having in that group. So the assessment was made available to all staff who were given 2 months to complete 48 questions, and it also included 3 of the same questions that were featured on the biannual participant satisfaction survey. So what you see here in this numbered list were the buckets and categories of the different questions. And this is the order that staff felt present the most need for change. So starting with systems change and environment and safety, those were the 2 where staff felt we had the greatest opportunity for improvement using a trauma-informed lens, and then in continuing down to workplace development, service delivery, and lastly, organizational commitment. The biannual participant satisfaction survey was made available in person, where people seek and receive social services, and via email for 1 month. So that was concentrated with the population that receives Ryan White services. And then the environmental assessment was pulled from the TI Oregon website, and it was used by the trauma-informed work group as well as volunteers to gather feedback on the physical space. So these are just a few examples of assessments that are out there, and links to these resources will be included at the end of the presentation. And what we learned from the assessments that we completed was that the goals we initially established are congruent with the areas that the TI work group had initially put down as what we felt presented the most need for improvement and opportunities for change. So moving forward, we plan to conduct this assessment to monitor our progress, provide quantitative data. It helps us to prioritize our competing goals or buckets of goals, and it'll be helpful to influence an action plan. It was also really great to elicit feedback and keep the conversation going and let staff know that their input and feedback is important to this collaborative process. So what's next in our process is to present our recommendations to the ED. We're going to work on developing an implementation plan, and we're also going to expand our work group to include members of CAP's other committees. So currently at CAP, in addition to the trauma-informed work group, we have a safety committee, health literacy group, trans-affirming committee, African American services, and a health and wellness team. So having those people in the room to figure out how we can work together, again, with the goal of creating an agency-wide initiative. To keep this topic fresh in everyone's mind and maintain momentum, we'll be presenting TIC moments that are bi-monthly, or I'm sorry, every other month we have staff meetings, so we'll be presenting those. And we're really at the point where we've been trained, we've done assessments, and now we need to create a sustainable implementation plan to parlay everything that we've learned and experienced. So with that, I'm going to pass it over to Katherine to take it from here.
Thank you, Laura. So you just heard two wonderful stories from two of our lovely Learning Collaborative members about the work that they've done locally, and I just want to also acknowledge that the Learning Collaborative is lucky to have both them and their organizations involved. They've brought great perspectives and experience to this, and so as much as they praised being a part of the Learning Collaborative, we are just as lucky to have them as members and the thoughts that they bring to this work. And if Julie started this conversation saying that we wanted the trauma-informed learning collaborative to kind of model what we thought a trauma-informed organization should be, and so similarly we would like this webinar to model what a trauma-informed approach should look like. So we want to spend the last time we've got together on kind of sharing the lessons that we've learned thus far about what a trauma-informed organization is, what are some of the important principles, and how to implement it. So I'm going to start off by just thinking about what a trauma-informed organization is. If that is our goal that we want to achieve being a trauma-informed organization, we have to really start with understanding what that means. And so as a group, we've kind of come together with the understanding that a trauma-informed organization is one that really understands how trauma impacts people in a variety of ways, as you see on the screen, recognizes that our services and our environment have to create spaces that are healing, that allow people to build healthy relationships, ensure safety, and regain a sense of control and esteem, which are critical to healing from trauma and to preventing re-traumatization, and that organizations should take all of this understanding and really incorporate it throughout the organization. I think we've heard reference before that from the differences in trauma-informed care, trauma-informed approaches, and trauma-informed organizations, and that's something that our Learning Collaborative has talked a lot about, is that in the beginning, a lot of the focus and the national discourse was on trauma-informed care on a provider level, from person to person. How are we approaching people in a trauma-informed way, and what does that look like on an interpersonal level when you're interacting with people? And then when we look at trauma-informed approaches, looking at kind of more of a framework on what are principles and what are key considerations and how you interact with people and how you develop trauma-informed relationships and interactions, and then moving towards a trauma-informed organization where we're looking at an organization that incorporates all of this understanding throughout their policies, their practices, their procedure, their organizational climate, making sure that the whole organization is incorporating a trauma-informed approach and framework. And especially for us, we find like that's really important for health centers and for people working with vulnerable populations. People who have experienced homelessness have experienced trauma. Homelessness is traumatic. So for our clients, we know that it's important to provide the best care that we can, that we must be creating trauma-informed organizations and spaces for them to engage in so we can provide quality care and access for them. And for our staff, it's important to be a trauma-informed organization. Our staff deal with a lot of high-needs clients, high-needs situations, deal with a lot of pressure environments and situations, and have a lot of emotional labor that is put into their job when dealing with vulnerable people in vulnerable situations. And so our staff need a lot of support, and it's up to the organization to try to provide that support through their policies and practices and procedures in becoming a trauma-informed organization. So it's something that's especially critical for our organizations and working with people experiencing homelessness. So through our research, kind of the homework that was mentioned that we put people through during our learning collaborative process, we came across a number of examples of what trauma-informed principles mean. If you want to participate, not as required homework for any of you as listeners of the webinar, but if you just want to see some of the homework that our Learning Collaborative members read through and looked at, that's in the resources pod at the bottom. So we've got some that talk about the concept of trauma and trauma-informed organizations. SAMHSA has a great concept paper on that. And then we've got some of the examples of the assessment tools that we looked at and that we reviewed where some of these principles came from. So we looked at a lot of models and assessments that kind of compiled some of these different principles. A lot of these principles were repeated throughout some of the different assessment tools, so we can tell that they are incredibly important. And there are others that were singularly on different assessments, but as through our discussions found that they are incredibly valuable to trauma-informed organizations. We really could spend an hour, an entire webinar talking about just these principles and how important they are to our practice and how to implement them correctly. But I just want to call a few out, and I think we've named several on this webinar so far that are critical. But our Learning Collaborative has really identified safety, trust, transparency, choice, cultural humility, empathy, trauma awareness, and building connections and being strengths-based as incredibly important for us as moving forward with principles that our Learning Collaborative thinks are important. But everything on this list is valuable in thinking about how trauma-informed your organization is. And then organizational domains, this list came out of that concept paper by SAMHSA that was referenced before and then is in your resource pod. This is general areas of an organization that can be reviewed to see if they align with trauma-informed organizations and organizational practices. We heard examples before about how the physical environment is creating a space where people feel comfortable both physically and emotionally, feel safe in those physical environment spaces. Training and workforce development, including the onboarding process and job descriptions, and a number of different areas that are critical to look at as you're evaluating how trauma-informed policies, practices, and procedures run throughout your organization. So some of the important steps that we see in becoming a trauma-informed organization are listed here. I also want to reference back Laura's slide, the roadmap that Trauma-Informed Oregon put through. Is a great place to start in thinking about some of these steps. Down in the web links pod, there's a link right there to the Trauma-Informed Oregon website, which has a lot of great resources there. But a lot of these steps are not linear, but steps that are important through the process of becoming a trauma-informed organization. I think you heard from two of our Learning Collaborative members and saw both of them are at different stages and what they've been able to achieve at their organizations. That's similar to all of our Learning Collaborative members. All 10 are at different stages, and it's completely valid to be at any stage in this process and to be considering what your next step is, because we know that becoming a trauma-informed organization is not a checklist. It's not a checkbox that you've done this thing. It is a constant journey to make sure that as a part of the organizational culture that you are constantly assessing and evaluating, are you being trauma-informed? Some critical steps that I've heard mentioned before that I just want to make sure that we acknowledge is having leadership buy-in and staff buy-in. I know our leadership and staff are often affected by a heavy workload, constant changing environment, and so there's a lot of competing priorities and competing needs for the time and resources to do these types of projects, but getting staff and leadership buy-in for this work is critical. Having a work group, a committee, some trauma-informed champions, people who will push this and do the work is critical. And then thinking about the implementation or the organizational implementation plan, as Laura had mentioned, thinking about that early in the phase is really critical. We want to make sure that kind of before we're doing an assessment or we're asking people questions about how trauma-informed organization we are, that we want to know what we're going to do with that information. How are we going to evaluate the results? How are we going to implement or the recommendations? What can we do? What can't we do? And how are we going to make this a part of our sustainable work culture? How is this group going to continue to function, and how is this work going to continue to function? So thinking about that organizational implementation plan and structure from the beginning really helps you set this up for success for a sustainable model rather than a one-time assessment that people are going to go through. So these are a number of steps that we have identified as important. But we also realize that there are a number of challenges in achieving any and all of these steps. So again, kind of want to just hear feedback from the room before we open up for Q&A, just about some of the challenges that you could see your organization facing or would foresee in implementing any of these steps in becoming a trauma-informed organization. So there's a poll on your screen, as you see. There's a lot of challenges there, but we're just asking you if you want to just choose the main challenge. So if you just want to identify one of these challenges that you think would be the most difficult for your organization to overcome. And again, we'll give you about 30 seconds to kind of look through all these options and think about what you think the main challenge your organization would face. Because I will note that this list of challenges came from our learning collaborative, so these are challenges that we know exist in most organizations, if not all organizations, in specifically in any organizational change plan, and then specifically around implementing a trauma-informed organization. So these are challenges that our learning collaborative has identified and that we're going to work to incorporate in our year 2 discussions about how to create a successful implementation model, but just from your perspective, wondering what you guys see as the main challenges. So I'm going to leave it open for just about 10 more seconds. Okay, so it looks like a number of people are responding, so thank you for that. It looks like staff workload has the most responses, and we know that that's a constant pressure. Staff have a lot of competing priorities and aren't always given time for a lot of the administrative work that they do, and so that's absolutely something to consider, is how we're building in concrete time for this work if we're asking staff to do it. Other things that are on the list with a high percentage, organizational climate and culture is always something to address. Sometimes our organizations need this work, but we're not prepared to talk about it. So it's how do we have the conversations that we need to think about this type of projects. Lack of awareness of trauma-informed approaches and a need for trauma-informed organization. I think that can go along with the organizational climate. Just why is this important to our clients and to our organization and our community? Starting with those conversations. And then kind of back to that organizational implementation plan, having clear purpose and goals and plan, and a process for implementing. So it seems like hopefully a lot of challenges, but hopefully some ideas for how to overcome those challenges or next steps. So thank you for participating in the poll. And now I will send it back to Julie so we can spend our last 10 minutes on the Q&A section.
Great. Thanks, Catherine. And thanks again to our presenters, Krista and Laura and Katherine. And if you all stay a little bit after the Q&A, so we'll spend the next maybe 7 minutes to respond to the questions that we've received. And please feel free to continue to submit your questions. But after the Q&A, we have a couple more slides just to show you some resources that you can look at after the webinar. So stay tuned for that. But for our first question, we've gotten a few about the collaborative and next steps, and if we're offering an opportunity for other agencies to participate. So I can go ahead and respond to those questions. We are asking the members of the first year to continue with us in year 2. We understand that some programs won't be able to participate, and we will find out in July when we renew our memorandum of understanding with the programs to see which programs will continue. And in that case, if a program decides not to go forward for year 2, we will have slots open, and Katherine and I are still working on how to determine if we're going to reopen the application process or how to determine who will we include for year 2. So that is an opportunity. But in any case, in year 3, our goal is to develop this toolkit based on all the information, feedback, experiences that we had over the 2 years, including all of the homework. So you'll have the list of resources. You can just see just a small sampling in the resources pod right now on your screen of some of the articles and homework assignments that we shared with the group. But the entire list of resources, other ways to get support in this work, and the change or organizational plan will be provided in that toolkit. So that will be at the end of year 3, and that will be available to the wide public. And I will say also, our vision for this project was a pilot for a standing offering from the council, so that we could provide this type of formal technical assistance and training, learning collaborative continually year after year for programs who wanted to participate and get support in this work. So we are testing this out as a learning collaborative standing offering model from the council, and so our hope after year 3 is that we can open an application process for other programs to participate in this peer support network for this work. I hope that answers the questions about the learning collaborative, and I'm happy to talk with you afterwards too if you'd like to discuss further. The next question, I'll be asking Krista and Laura to respond about their timelines. So if they could just talk a little bit about maybe their time frame or timelines around the work that they have done up until this point and their plan moving forward. So I'll see, maybe Krista, if you would like to start us off.
Great, thank you. So for us, our timelines are, we've started implementing some new policies, employee handbook updates. For us, what we really want to do is complete the agency assessment, which we're going to be doing in year 2 of the Learning Collaborative. And I think from there, we're going to have to focus on some formalized trainings that are specific to the assessment results that we receive. And we know that we have pretty solid trauma-informed care training that is on point, it's required, and we want to take the approach to focus more on the agency staff, our employees, our facilities, policies, procedures. We expect that we'll be able to complete that, well within year 2 of the Learning Collaborative, and then at the end of year 3 probably have to make adjustments based on more things that we've learned. I think for us, we're kind of looking at this as a process. It's definitely not one and done. And within our agency, I think we're looking at it more like a continuous quality improvement. So we're going to assess, we're going to make changes, implement, reassess, and kind of continue that loop to refine and to get to the best place that we can be with becoming a trauma-informed organization.
Thanks, Krista. This is Laura. Yeah, so similarly, we see this as a continuous process that does involve continuous education and training and agency-wide communication. When we started the trauma-informed work group, we really wanted this to be an action-oriented work group, recognizing staff turnover, that staff have multiple responsibilities, and that the commitment to a work group in and of itself can be time-consuming, and that the topics that we're dealing with can be difficult for folks to talk about. So we really wanted to set out to accomplish some concrete things. And in the first 6 months, we established goals of identifying a staff-centered initiative and a participant-centered initiative. When we started down that road, we realized that we wanted to do additional trainings before we committed to one goal, so that when we do identify that, we'll be in a place where we can implement it and support it in a way that is sustainable. So our sort of soft goals were to identify a list of goals, to do trainings and a few assessments, which we did in the first 6 months. So our next step is to convene with management and present recommendations to formulate a plan. Some of the questions that we have that were just discussed were, will these responsibilities be held solely by the work group or amongst other groups? How will the responsibilities be handled as they expand and as this becomes an agency-wide initiative? What role will leadership play in it? How will people be expected to balance workload? And how will we work collaboratively with participants? And that's a piece that we haven't been able to get to yet. We've done the biannual participant satisfaction survey, and we're providing updates to our community advisory board. But at what point will we be able to come together and sort of hear what their recommendations are? Hopefully it'll be at the point where we have a better understanding of what we could offer and what we could follow through on. So those are some of our next steps as we continue with the continuous process of ongoing education and training, which CAP has emphasized for all employees, not only in the trauma-informed realm, but as an incentive for all employees to continue to get the education and training that they need to do the work.
Great, thank you so much. We also received a question. Maybe we'll respond to a couple more questions, but please continue to submit your questions. We will respond to them in writing or following the webinar. But we did receive a question about whether trauma-informed approaches could be used in an educational setting. And so I'm not sure if this is higher education or elementary or primary school. It could also be, we could also be thinking about patient care education. But the National Council and our work is focused primarily on health center populations in primary care, but we do have a great collaboration with the School-Based Health Alliance, and they do a lot of work collaborating with the school system and health centers to create a trauma-informed system. So I'm aware that they have several resources on trauma-informed schools. And also another great resource for school systems is the ACES Connection website. So they provide a lot of resources around trauma for children. So for the school system, they would be able to address it at that organizational or systematic level. Another one resource, and then we'll move on to the next question, a documentary. So there's a few, but the one that's coming to my mind right now is Paper Tigers, and it was a documentary about a school system that was implementing this type of organization-wide change to become more trauma-informed. So those are a couple of resources, and I'm happy to follow up via email. I can pull up several and send those to you. So if you'd like that, you can let us know. The next question, I'll send it to Krista. I don't see it on my screen anymore, but it was about how do you respond to clients who may have substance use issues, or also if there's any sort of hostility between staff and consumers. So I'll pass it to Krista. Sorry, I don't have the exact language in front of me, but see if Krista and then maybe if Laura wanted to add to that, that would be great.
Thank you. And I think I might have deleted that question accidentally, so I'm sorry. I kind of wanted to explain for us where that would come in. So for us, the substance use, the co-occurring, the homeless, and the trauma is really happening for us out of our drop-in center. So our drop-in center is for homeless youth 14 to 24. And the things that we've tried to do there that we feel have been successful is, following a harm reduction model. We also obviously use a trauma-informed care approach and work with all of our staff at that location to understand positive youth development. The center itself is a really low barrier to entry, and kind of before anyone goes to work at that location, we make sure that we do a solid onboarding, a solid peer training. We do train everyone in crisis prevention intervention. And for us, we don't have any, we're not allowed to touch our clients. We have no restraint or seclusion policies. So trying to take those things into, our approach to dealing with someone who is unhappy or maybe has the co-occurring type of disorders. What we've seen for the youth that has been very successful for us in serving the clients is a utilization of peer staff. Where peer staff can sometimes cause our agency struggles is on the HR side, and really making sure that we educate our staff on what it's like to have peer staff and making sure that we have a solid training program for them. But I think that it's possible, and I think it's a multi-pronged approach, and I don't think that there's one right answer for every client across the board on utilizing that trauma-informed care and those trauma-informed principles with each person. I think you have to be able to train your staff and allow them to assess and help and use the approach that they feel best. And the best we can do is provide them with the tools, resources, and training that they need to be able to address that traumatized youth or individual who is coming in with the co-occurring disorders.
Great, thank you. And we're going to move on to wrapping up the session today. I do want to share a few resources and respond to some questions about available training opportunities around trauma for all staff at your programs. If you'd like to reach out to our technical assistance manager, Michael Durham, you can also submit a request on our website, and he can get in touch with you about available trainings or resources for your staff. Also, all of these slides and these resources will be available. You can actually download them on your screen right now in the resources pod. If you just scroll down, you can click on webinar slides, highlight it blue, and then hit download. But again, this recording of the webinar and the slides will be available in 3 business days on our website at www.nhchc.org. We will respond to any questions that we did not get to today in writing via email. Also, lastly, at the close of the webinar, an online survey will pop up. It's to evaluate the webinar, so that will automatically open in your web browser, and we just ask that you please take just a few minutes to complete that, just so we can improve your webinar experience in the future. Again, please visit the Council's website for a listing of resources and also upcoming webinars and other educational products. So we appreciate you all spending your time with us this afternoon, and I hope you have a great rest of your day. Thanks, everyone.